Good morning, everyone out there. This is Dr. Nick Tulo with another Saturday morning live stream. I'm very happy to be here. I had to take a couple of weeks off because I was on call one weekend and other things, but I have a really cool case to present to you this morning, and I think you'll enjoy it because it happens all the time when people refer patients for definitive problems or arrhythmias that were diagnosed on a cardiogram, and then it just doesn't turn out to be what you would expect it. It's just not what it was billed. So we're going to get to this case. So let me change my view here. Hello, good morning. And so this is actually a case of a 70-year-old person. I'm going to read this. Has a history of chronic kidney disease, had aortic valve replacement and mitral valve repair in 2012, had some complications with that, but otherwise had normal left ventricular function. And they went to their primary care doctor and they get an electrocardiogram. The patient was asymptomatic at the time. But let me show you what the cardiogram showed, and you can see what you think. Okay, so here's the ECG that was obtained in the doctor's office. And if you glance at the whole thing, you can see it does appear to be irregular. In fact, you have some long intervals and short and long and short, and there's sort of like this no pattern to it. So it's irregularly irregular. And in addition, if you notice, there is an RSR prime in V2 and an R prime in V1 with a deep S wave in the lateral leads. So there's a right bundle branch block. And in addition, if you look at the axis in the frontal leads, if this is lead 1, you notice that it's isoelectric in AVR. So when it's isoelectric in AVR and it's going away from 2-3 and AVF, that means the axis is up here someplace at minus 60, and that tells us that we have a left anterior hemiblock. So the patient has a bifascicular block left with a right bundle left anterior hemiblock. They have poor R wave progression, but notice how deep the S waves here in the lateral leads. So we like to call this late transition because it's not really that there's a lack of anterior forces. It's more that the heart is sort of rotated in a clockwise fashion when looking from below, and it's an electrical phenomena that we see with anterior and posterior hemiblocks all the time. So I generally just call it late transition, and it's part and parcel of the anterior hemiblock. But the patient was referred to me because of this irregular heartbeat, and they diagnosed the patient as having atrial fibrillation because it was irregular with no particular pattern to it. And there just seemed to be a little jiggly stuff here that the internist felt was consistent with atrial fibrillation. So he actually put the patient on Eliquis. Belu Daniela, good evening. Thank you. That's right. It's evening in Europe, and for those of you who are watching this live, I really appreciate your being here and being able to participate. And every now and then I'll kind of look over and see if anybody's has a comment. But so with atrial fibrillation, they felt, of course, the patient is elderly with underlying heart disease, and the patient was placed on Eliquis, which is apixaban, and that's a very good anticoagulant to use for this problem. So the question is, when you have a patient referred to you by the internal medicine doctor, and they say the patient has atrial fibrillation, don't just take it at face value. Always look, because I see internists and even cardiologists sometimes misread an ECG. So you always want to take a closer look at what is actually going on. And we will take a closer look at this, but I want to show you what the ECG looked like in my office. So let's see if I can pick one out. Okay, so this was the ECG that came off of my machine. And as you can see, something looks a little bit different. The patient is now pretty regular. at a rate of about maybe 80 beats per minute, and actually 90. And the ECG machine read it as sinus rhythm with premature atrial complexes, because every now and then you have like an early beat here and then here. So these were the PACs that the machine picked up. And if you look at the rhythm strip down here, it almost looks like, well, let me actually have a larger version of this. So if you look at the rhythm strip down here, let me just create a new layer. You can see what looks like a P wave in front of each QRS, at least in V1. But do you believe it? Always think, what else could it be? And I always teach my students on ECG Academy. If you're interested in learning more about ECGs, by the way, there's a link down below where you can actually check out my online video tutorials at ECG Academy. But you always have to look a little bit more carefully when something sort of like doesn't fit right. So what I see in lead 2 is atrial flutter, and I'll show you why. I can make this a little bit bigger and just sort of drag this around a little bit. So here in lead 2, what you're seeing is a downsloping segment that rapidly resolves, and this sawtooth pattern is seen throughout the whole picture. And those of you who are used to diagnosing atrial flutter will recognize this right away. Those of you who are still beginning in ECG analysis, maybe it's a little bit more difficult, but let me show you the original cardiogram that was sent to me by the doctor. And if you look here very carefully, there's a lot of artifact in the baseline. So there's a lot of very small high frequency jiggles, but you can still see that there was a sawtooth pattern in the baseline. And you can see it here as well. So when you have atrial flutter, now it's a whole different ball game. First of all, Eliquis was perfectly fine to use because atrial flutter does increase the risk of stroke just like atrial fibrillation does. But you see, atrial flutter comes in a bunch of different varieties. And there's a typical atrial flutter, which this looks like. It has that gradual downsloping flutter wave that quickly resolves, and you get this sawtooth pattern that's very easy to recognize in the inferior leads. And if you look here, I'm going to show you the EKG again. And in V1, you have in the inferior leads, the sawtooth pattern is down going, and in V1 here, it's going up. So when the inferior leads in V1 are going in opposite directions, that usually indicates typical or a common atrial flutter that's going in the counterclockwise direction. I'm going to explain what that is, because it's important that you recognize it, and there's a good reason why. Because in atrial flutter, pretty much it's always the same. What you have is let me go back to my blow up. So, okay, so here we are. So your heart is sitting, pointing to the left side, and the tricuspid valve is sort of on the front part of the heart because the right ventricle is anterior and the left ventricle is posterior, right? So the tricuspid valve serves as the anatomic obstacle that allows re-entry to occur. So in typical atrial flutter, that classic sawtooth pattern that's going down in the inferior leads and up in V1 and V2, what you'll find is that the electrical signal is traveling in a counterclockwise direction around the tricuspid annulus, going up the atrial septum and then down the lateral wall of the atrium. So it's chasing its own tail around and around the tricuspid annulus, and that's what gives you the classic representation, the typical appearance of typical atrial flutter. It's the most common atrial flutter to begin with because the tricuspid valve is a very large anatomic obstacle. And the way the fibers are arranged in the in the bottom part of the right atrium allows some delay that allows this reentry circuit to perpetuate itself. I'm just checking to see if there are comments. Thank you. Yes, well, White Adams said it looks like flutter and the longer interval, and you're absolutely right. But it's a right bundle branch block, and the left axis deviation is from the anterior hemiblock. And that's a whole thing we can get into at a later date. Why does the left anterior hemiblock cause a marked left axis deviation? I actually go over that in the intermediate level of the ECG Academy. But it has to do with the fact that the posterior hemifascicle, which runs down the bottom part of the left ventricle, depolarizes earlier than the anterior hemifascicle, so the signal has to travel up into the patient's left, and that's what causes that axis deviation. But let's get back to the idea of this counterclockwise atrial flutter circuit. It's actually pretty much always the same in normal individuals, and so it's a very easy target for catheter ablation. And there have been studies to compare catheter ablation for typical atrial flutter versus medical therapy. And if you just put the patient on an antiarrhythmic drug and do a cardioversion, there's an 80% chance that that patient will recur within a year or two. But if you are able to interrupt that circuit with an ablation procedure, then there's an 80 or 85% chance of a cure. That means after 2 years, the vast majority of patients are still in a normal sinus rhythm. So let me kind of like show you what that ablation procedure looks like. So we did indeed bring the patient to the EP lab. And let me just show you what we do is put multiple catheters in. And what the recording shows is on the top, this is an EP recording. And on the top, we can see the surface ECG. This is AVF V1. So you can see that right bundle branch block pattern in V1, which is still there. And you can just sort of barely make out the fact that you have this sort of fluttery pattern in AVF. But more importantly, in the coronary sinus, which is recording left atrial activation, and in the right atrium, which is where the ablation catheter is, you have this pattern of atrial activity that is very, very regular, perfectly regular, at a rate of around 220 beats a minute or so. And so this is what atrial flutter looks like. It's an organized electrical activity. Oh, I'm not showing you I'm sorry. Let me go back. Let me change my view. See, this is what I should have been showing you, is the surface ECG on the top with V1 showing a right bundle branch block. And then you have the coronary sinus, which is down here in the left atrium, showing this very regular atrial activity at about 220 beats per minute. And this is what atrial flutter looks like in the EP lab. So we can actually use a three-dimensional mapping system. We use the CARTO mapping system, but there are a lot of others. And I'm going to show you what the CARTO map looks like and give you and explain what this is all about. What does this crazy thing mean? So let me just change my color because you're not going to see blue in here. So now, make it a little bit bigger. So with this crazy multicolored, this is really cool looking illustration shows, is here's sort of like the view of the heart, the way we're looking at it. And we're looking basically in the LAO direction, so looking kind of like down the barrel of the heart. So this hole right here is actually the representation of the tricuspid annulus. And the way that we are able to map is we take a special mapping catheter, and we can, these little dots are points where we've taken the catheter and told the computer where in three-dimensional space the catheter is located, and then look at the timing of the electrical signal at the tip of the catheter and compare it with a reference. And it allows us to not only generate the three-dimensional anatomy, but the color represents the time compared with the reference, with red being very early. And so you have early area activation in this region, and then it turns into orange and yellow and light green and dark green, and then sort of cyan and around to blue, and then purple is latest. And so what you're able to do is see that the electrical signal is indeed traveling in a counterclockwise direction around this tricuspid annulus. Isn't that cool? So that's how we know for sure that this is typical atrial flutter. Now, how do we interrupt the circuit? Well, let me get rid of this drawing first, and then I can actually rotate this little map. Okay, and now I've rotated this three-dimensional map so that now we're looking at, so almost rotating it this way. So now we're looking at the side view with the right ventricle sort of over here. And let me just add another drawing group. So you got the right ventricle, which is going to be down here. You got your tricuspid annulus. This is the representation of the right atrium. And down here is where the inferior vena cava is going to be. So let me see if I can show you where that's actually located. So this is actually a video that I can play. So if I roll it up here, you can see this is the tricuspid, oops, sorry, need another layer. So this is the tricuspid annulus, and this is the inferior vena cava. And this is the isthmus through which the signal has to travel. It has to go over, as it's going around in a counterclockwise direction, it has to squeeze through that isthmus of tissue between the tricuspid annulus and the inferior vena cava. And that's the target for ablation. You can see these red dots over here. Those are my ablation lesions. So, so let me just show you the X-ray of what it looks like. Let me find, okay. So now, this is an X-ray picture, a fluoroscopic image in the EP lab. And what you see is the patient actually has a pacemaker. But what you see is, I didn't mention that, but it's not really important. These images are from a different patient, but just to illustrate how we go about doing an ablation, we have the His bundle catheter, which is right here. We have the coronary sinus catheter, which is going up the left side. And this right here is the ablation catheter. Let me just pick a different color. So in essence, the tricuspid annulus is here, basically, and the inferior vena cava is going to be here someplace. Yeah, let me just erase that part. So the leads are coming up the inferior vena cava, and we have this ablation catheter that's sitting right at the tricuspid annulus. And then what we do is we make a burn right there. It creates a kind of a pea-sized scar right at the edge of the annulus. And then what we do is we move the catheter back a little bit, so then it looks like this. So we have the tricuspid is now here, and we've moved back a little bit, and we had that first burn, which is here, and now we make another burn here. And then we pull back again, okay? And we follow the landscape. So if the inferior vena cava is here, and the tricuspid is here, that isthmus of tissue is going to be this way. And so it's not exactly like, it's actually when you're in the lab, you know that you're contacting it, because the catheter actually can measure the contact force, how much pressure you're putting on. You have 5, 10, 15 grams of force, so you know that you're actually in contact with it. And then we pull back again, and we're almost at the margin of the inferior vena cava here. And I'll show you what happens when we finally reach that margin. Here's the very edge of the inferior vena cava. And let me show you what happens. So here's in the EP lab where we get to the very edge of the inferior vena cava, at the very end of that series of burns. And right here, we turn on the power. And here, you can see the atrial flutter. And as soon as we turn on that power, within 2 beats, within about 1 second, the flutter stops. Because now we've created a line of block in that one little area in the heart. so that the signal was trying to go around, and now it reaches a dead end. It reaches a speed bump, and now the patient is back in sinus rhythm right here. So you can see sinus rhythm. Isn't that cool? That's like so great. And it only takes like maybe 45 minutes, an hour, something like that. It's not a difficult procedure. It's highly effective. 95% of the time we can get the flutter to terminate, and then we pace on both sides of the line of block to make sure that we have block there. And it's such a cool procedure. See, okay, so here's the tricuspid annulus, and the inferior vena cava is coming up. So it's this isthmus of tissue between the two that we're burning. So we start at the annulus, and we pull back and pull back and pull back. And when we get to the inferior vena cava, it blocks. So now you have this basically a line of scar tissue that we've created. And it's very benign. It doesn't cause any problems. But what we do is we pace on one side, and we make sure that the signal can't get through. And then we pace from the other side, and we make sure that we have bi-directional block. And basically, that's associated with a really great outcome. 90% of the time, the flutter never comes back. And with this particular patient, since he never had atrial fibrillation, really, he only had flutter. We were able to, after 3 weeks, we were able to stop the Eliquis, stop the anticoagulation, just put him on aspirin, and he did really, really well. So the important thing in this live stream is that you understand that just because somebody tells you it's atrial fibrillation, you look yourself, make sure it's not something else. I refer to atrial flutter as the great pretender, the great imitator. Because sometimes it'll look like, if it's like 3 to 1, you might just see one single flutter wave and the other two are buried someplace, and it may look like sinus rhythm. If it's 2 to 1 flutter, sometimes you don't see the second flutter wave and you think it's either sinus tachycardia or SVT or some other crazy thing. And in this case, where you have variable AV block and the flutter waves are relatively small, people think it's atrial fibrillation. So make sure you look for those flutter waves, because if you diagnose it, you know that you can then refer that patient on for a flutter ablation, which is highly, highly effective and very, very safe, a very low risk procedure. And then the patient could potentially come off of the anticoagulation and go on from there. So I hope this was really interesting to you guys and gives you some insight into my world of electrophysiology. And if you enjoy this content, please share it with your friends. Make sure that you down in the description below, there's a link to click and subscribe to my YouTube channel, which is ECG Doc. And if you'd like to learn how to read electrocardiograms like an electrophysiologist, like a arrhythmia specialist, then there's also a link for ecgacademy.com, which is a complete course, online, self-paced, all video tutorials that I recorded. Anyway, I'm very glad that you were able to make it here, and hope to be able to do this next week. And until then, thanks for watching.